Thank you, Dr. Quresh, for this kind invite for this very nicely crafted instruction course. So, as he said, we are still not moving towards advising MRI. So, there are patients with headache. What is our role as an ophthalmologist? Can we contribute to the investigation and management of the patient? And what if we don't do our role properly? How that patient can actually be misdiagnosed or be taken on a long round trip. So to prove that, let me show you this patient, 34-year-old female. She had a sudden painful loss of vision in the right eye. She also complained of right-sided headache with eye pain. She presented last year, around a year ago, in the March. She was seen, and as Dr. Maskati mentioned, she was seen by the retina surgeon with dilated pupils. However, the record, when we went back to the record, this is what it showed. Patient had a 6:36 vision in the affected eye. The patient presented with pain and loss of vision in the right eye. The affected eye had 6/36 vision. Color vision was slightly down. Ocular motility was full. And this is how her optic nerves look like. You see there is clearly a disc edema of the right side. The left eye optic nerve is normal. Patient did not have any complaint in the left eye. So the treating physician at that time said that, oh, patient has a 6:36 vision, acute loss of vision with pain and headache. This does sound like optic neuritis. Patient was sent for MRI brain in orbit, which was reported saying, yeah, probable optic neuritis, clinical correlation, as all report will end with clinical correlation. So, right. So patient then was sent to neurologist. Before that, what would you have done? Here is a 34-year-old female with an acute loss of vision. Vision is 6:36. I showed you the optic disc. What would you have done? IV steroids, oral steroids, or just watchful expectancy? Would you, how many of you would you say that we can just wait, this will resolve on its own? It is probably just a passing infection. Any of you think like that? No. How many of you would give oral steroids? You say, look, let's start steroids because then we can follow up with the patients. Would you start with oral steroids? Well, that's not the right course. If this was an optic neuritis, patient should be given IV methylprednisolone, and ideally it should be in a setting where the emergency can be managed. So most of the time patient end up going to neurologist to make sure that a neurological evaluation is done and IV methylprednisolone is given. So that's what was done for this patient. And the note, I mean this is retrospective, note mentioned that patient was given 2 doses and patient was jumping with joy, saying great, now vision has improved, lovely, everything is going on well. And she said that vision, now quality of vision in both eyes have really dramatically improved. However, when patient's steroid was tapered, she came back around 2 months later. So since patient was doing well, since patient went into the neurology universe, patient never came back. But after around 2 months, when the steroids were being tapered, patient went to neurologist saying my vision has gone bad again in the right eye. And that's when patient was referred back to an ophthalmologist to say that what was going on. And here if you see now, actually patient has a large patch of choroiditis with probably CNVM on the right side. Okay, so was there something which we missed out as an ophthalmologist? And that's where patient went on this complete wrong route of MRI, IVMP, improvement with IVMP, and then now the deterioration. So went back and reviewed the pictures, and here is the FFA, because it was seen by a retina surgeon as rule, as Dr. Maskati was saying, FFA was done. So we had an FFA of right eye done in March and then in June. And you see there were already some amount of inflammation which was going on. But if you miss this or if you ignore it, I would say it's okay, it's all right. And here there is clearly now there is a inflammation in the patient was strongly positive for MAN2, chest X-ray was positive, patient was started on appropriate treatment. However, what was our role? And that's the crux of it. So the pointers where we said that maybe this was not really a problem of optic neuritis was there was a disc edema, there was a bilateral problem. Then we went back and checked the notes, and somebody had mentioned that maybe there were some pigments on the lens and vitreous cells. The optic nerve dysfunction was normal. One telling thing was just 2 doses of steroids and patient had a dramatic visual improvement, which is not really a case with a typical optic neuritis. However, the most important point which was missed out in the initial checkup was this, which was, and Dr. Maskati had already built the platform for this. They said query RAPD. With that kind of disc edema, with this kind of vision disparity between two eyes, I would expect an impressive RAPD if this was an optic neuritis. So this was an inflammation, uveitis, posterior uveitis to begin with, because that will not cause RAPD with this kind of disparity, and that was missed out. So probably if RAPD was checked by the treating doctor himself, or if the examination was done little more because of this finding, because optometrist had mentioned query RAPD, then we would have picked up the right diagnosis. So that's the importance of examining pupil, and also saying that just because patient complained of headache, MRI was actually, it deviated the whole thing because it said query optic neuritis. So to check RAPD, what are the steps that we need to follow? We need to make sure that we don't miss out on RAPD, and for that we need to make sure that we follow the steps. It has to be done in a dark room. Patient looks at the far object, not at you or not at your torch, and the full form of RAPD is relative afferent pupillary defect. You are comparing the health of one optic nerve versus the other. So if you have to compare the health of optic nerve, and this you are doing by illuminating the pathway, you need to make sure that the illumination of both the pathway is equal. So you need to make sure the torch is held at the same angle in front of the right eye and the left eye. It is this way, doesn't matter, but it has to be the same angle and for the same amount of time. 3 seconds here and 3 seconds here. So 1, 2, 3, 1, 2, 3, 1, 2, 3, and within 2 or 3 of these cycles, you will pick up the relative afferent pupillary defect. So that was an importance of RAPD, our role, and that headache is not really headache is not the indication for MRI in all patients. This patient probably would have required the retinal evaluation if she was examined. This is a 24-year-old female, complains of headaches, very mild visual problems, visual acuity is 6.6, and this is how her fundus looks like. There is a florid bilateral disc edema. There are some hemorrhages that you can see near the optic disc in the left eye. And you can see here patient also was complaining of little bit of diplopia in the left gaze. I don't know whether it's clear, but there is that little limitation of abduction of the left side. So that gives you a clue. Patient complaining of headache in an age group where raised, so this is pointing towards raised intracranial pressure. And a diplopia, a false localizing sign where there is a minimal limitation of abduction on one side. This is more, this is just an example of how false localizing can look like. This patient had very clear limitation of abduction when he looks to the right of the right side and of the left side. Bilateral limitation of abduction is more common as a false localizing sign in raised ICP, and this is how it looked like. So these were all pointers towards raised intracranial pressure. Our role now is to make sure that we take the documentation of disc edema, look at the OCT, look at this. So OCT, we need to do two things, RNFL thickness and GCC complex. And you see here that there is a significant thinning of GCC, and this patient would require an aggressive treatment. So this patient where there is a headache, there is a clear sign that there is a raised intracranial pressure, you need to advise MRI. However, why did I put that case? Because I am supposed to say that headache MRI is not required for all headaches. Is to contrast a very similar patient, a 10-year-old female. She presented for a second opinion with reduced vision for 4 months. 4 months ago, she was complaining of headaches and a little bit of ear problem. So she went to neurologist 4 months ago. Neurologist saw the fundus with direct ophthalmoscopy and so you have headache, you have some tinnitus, you have bilateral disc edema, this is raised intracranial pressure, admitted the patient and started the treatment. The ward referral, the ophthalmologist was called to the ward to examine the patient. Ophthalmologist went to the ward, saw the patient and said, yes, this is bilateral disc edema. So patient continued on acetazolamide, but because there was no improvement in vision, 4 months later, she came for second opinion. And you see, you still find that the disc, there is an axonal swelling. So what was the cause of reduced vision? Actually, there was, again, this patient had bilateral vitreous cells The vision was going down because of cystoid macular edema. So this patient had bilateral intermediate uveitis, which caused disc edema, and cystoid macular edema was the cause of reduced vision. Headache was incidental. So again, while headache is a sinister symptom which requires a thorough investigation, and a lot of times MRI will be required, but as an ophthalmologist, we need to make sure that the origin of that headache is not from the eye. I give you a few examples where inflammation of the eye, uveitis, can produce headache. There are, of course, other problems, like somebody who is working on the computer for a long time. I mean, much more common problems like inadequate convergence, insufficiency of convergence, accommodation, asthenopia, uncorrected astigmatism. They all can cause headache. So we need to make sure that we have a thorough, as Dr. Maskari said, thorough investigation of from the eye side before we decide that patient has to go to neurologist. Because please remember, once you send the patient to neurologist assumes that the eyes are fine, and he obviously then proceeds according to his algorithm, which would be to do MRI and give steroids. So that's something which I wanted to highlight, to say that not all patients with headache would require MRI. Thank you.